Good morning. This is David McDonough. I'm the neuroanesthesiology editor at openanesthesia.org. On behalf of IARS and A&A, I thank you for listening and want to extend a warm welcome to Dr. Eric Sun. Dr. Sun is an assistant professor of anesthesiology and of health research and policy at Stanford University. In the November 2017 issue of A&A, he published a review article titled Chronic Opioid Use After Surgery, Implications for Perioperative Management in the Face of the Opioid Epidemic. This is certainly a timely topic in anesthesiology as we look to modify our practice in order to help the nation out of this crisis. So Dr. Sun, thank you so much for joining us.
Oh, well, thanks for having me.
To get started, when I was in medical school in the 1990s, there was a shift in that you were considered a bad doctor if you didn't prescribe opioids for pain. And there was great concern that we were undertreating pain. And now it seems that 20 years later, we've come full circle and seem to have played a large part as physicians in, not specifically as anesthesiologists, but as physicians in general in creating this opioid epidemic. How did we get to where we are today?
Yeah, well, I think in terms of how we got to where we are today, I don't know, there's a lot of great sort of formal work to specifically state why. I mean, I think it would be a lot of what you pointed out, that sort of there's been change towards viewing pain as a fifth vital sign and therefore encouraging physicians to be extremely aggressive about treating it. That could be made, I think, or that maybe sort of additionally affecting that would be things like, review sites and Press Ganey scores, all of which sort of have given physicians a lot more incentive to be aggressive about treating pain. And so there's probably been sort of maybe an overcompensation towards the other direction, I think.
Well, can you briefly discuss the consequences of opioid use, particularly following surgery?
Yeah, I mean, I think a lot of anesthesiologists would know sort of the basic kind of complications, respiratory depression, ileus, sedation. In our paper, we talk about some other more systemic consequences, so increases in length of stay, increases in costs, and readmission rates. Those obviously are bad for the patient, but also going forward and sort of the way physicians are going to get paid, those are things we're going to care about because payers will start to penalize us for those things. But then the final one is just, one thing we talked about in our paper is a lot of people, after they get surgery, they don't use all the opioid they're given. And so there's also the possibility that this is a route for diversion and misuse.
So I was surprised with the statistic that you put in the paper that over 60% of people receiving 90 days of continuous opioid therapy remain on opioids years later. I think that was specifically in the setting of recent surgery. Can you elaborate on the risk factors for these patients who go on to have chronic opioid use?
Yeah, so the risk factors for chronic opioid use, we talk, there's a lot of studies that found different ones, but I think the ones that are kind of common to all the studies are going to be preoperative opioid use. That's probably the strongest one by far. Also the type of surgery. So, I don't think this would surprise a lot of us, but, orthopedic procedures, for example, are associated with the higher risk. So, those are the two big ones. The others that studies have found tend to be, say, males, for example, maybe at higher risk, the presence of depression or anxiety before the surgery, as well as substance or alcohol abuse. Those would be the ones that people have found.
So what do you recommend when we identify these patients in the preoperative clinic? How do you approach them?
Yeah, so I think the thing to do when you identify these high-risk patients, you have time when you identify them pre-op to sort of identify what's my plan going to be to manage the pain during the perioperative period. So really, do I need to set up a pain consult preoperatively? Is this something that, say, blocks or other things could be helpful for? Do I need to let those people know ahead of time? And also just talking about the patient. If you have chronic opioid use coming into the surgery, it's going to be a challenging time. And so I think sort of patient counseling is also helpful.
Is there an ideal way to modify current anesthetic and surgical practice so that we can get people off opioids more quickly in the postoperative?
It's a great question. It's sort of the big question we put in our paper because I think there's lots of things that we would like to do as anesthesiologists that we think can help. So I kind of alluded to them like, regional anesthesia or epidurals, I guess, more neuraxial type stuff. Multimodal anesthesia we talk about, such as the use of adjuncts, ketamine, lidocaine, Tylenol. We talk about all these things and, there's just really, the literature is either mixed or non-existent. I think in general for most of these things, I think the good news is that there's evidence that doing these things is very helpful in the short term, at least during the stay. So they're associated with using less opioid while the patient's in the hospital, associated with lower length of stay and potentially less readmission. So I guess sort of that short-term thing. these interventions seem to help, but really longer term, one of the things we mentioned in the paper is there's just not that much evidence that they help. When I say not much evidence, what I really mean is it's just not that many studies doing there. So I think that sort of is the next horizon. Is we know what the risks are. We know that patients undergoing surgery are at an increased risk of chronic opioid use. And so what can we do to reduce that? And I think sort of research on that is really the next horizon.
Now, what about from a practical standpoint, if especially for the surgeons or surgical residents who have a patient that's, they're sending home either for same-day surgery or at the end of their post-operative hospital stay, how do they avoid the trap or avoid getting a patient into trouble by overprescribing opioids? What's a practical approach to giving the patient an opioid taper? What kind of follow-up do they need?
Well, I mean, I think close follow-up is the key one. I mean, opioid taper, I'll be honest with you, I don't really do pain medicine. That's just not me. So that I know less about. I think sort of knowing your patient well, kind of, asking yourself what is an appropriate, for example, course. Probably not everyone needs a 30-day course, for example. So I think knowing your patient well and the surgery well, prescribing a realistic course of therapy and following up, I think just sort of the practical things a person can do.
What are you guys doing at Stanford in this area?
Well, I think, so one thing you had kind of alluded to before, so I think now there's much more of an effort to sort of identify high-risk patients pre-op. So it's on our pre-operative evaluation if they're using opioids, kind of as a checklist, like how much are they, enter what they're using, so on and so forth. And if certain criteria are met, so then it kind of automatically calls for a pain consult, or, it's the person doing it knows to call for a pain consult kind of preoperatively. I think like many institutions, we're trying to build in surgical pathways like ERAS or the perioperative surgical home to kind of, again, just kind of throughout the perioperative period, develop pathways to hopefully minimize opioid use. I mean, some of this is going to involve sort of interventions. I mean, for the anesthesiologist, I think a lot of it involves interventions early on, like, regional anesthesia, getting that, and the use of adjuncts, sort of standardizing that. So those are the things we're doing.
We're doing similar things here in Dallas in our spine population, for example, the spine surgery patients. There's a psychologist in the spine clinic, pain management, okay. PM&R physicians are there. And so these high-risk patients, can be identified and then referred to pain management, hopefully weaned off their opioids to some extent prior to surgery, and then have follow-up post-operatively.
Right. Yeah. So I think that's sort of the systemic factors. And again, just, I think that is the next thing for research. Like, it's one thing I'm trying to work on a little bit, these sort of system-wide changes. Again, what's their sort of effect on this?
And your connection with health research and policy, how does that play into your research?
By training, I'm an anesthesiologist, but I'm actually also an economist. So a long time ago, I got a PhD in economics. And so I've always had an interest in health policy. And I always like to say stuff that's more dollar signs involved to it. And so, some of my research is on pain, some of my research is more on sort of broader health policy issues. So like there was a time when most physicians, I think as anesthesiologists not as much, most physicians tended to be in solo practices. That seems to be changing over time. More and more kind of physicians, that's not what they're doing. They're practicing in the context of really large group practices like Stanford, Mayo Clinic, Cleveland Clinic, so on and so forth. And so like some of my research is looking at the effects of that and sort of what the economic effects of that. So that's sort of the other side of my research agenda.
I see. Okay. All right. Well, thank you very much. I appreciate your time
and thank you, David.
Expertise.
All right. Thank you.